Good morning. My name is Lèlita Santos, and I am the president of the Portuguese Society of Internal Medicine. It's a pleasure for me to be here, and I thank the invitation. Greetings to all the other speakers and attendees in this conference. Well, I'll talk about diabetes modification drugs, and at the moment I have nothing to disclose in what concerns my talk. Our agenda will be other standards of medical care in diabetes, recently reviewed, as you know, new drugs and how they fit, beyond glycemic control and future perspectives. Everything, of course, very summarized. Well, the last 7 years brought to us a new era for the treatment of type 2 diabetes. New drugs which have proven to reduce cardiovascular risk and have several cardiovascular and renal benefits, and also benefits for other comorbidities like chronic kidney diseases and heart failure. These types of drugs, these classes are SGLT2 inhibitors and GLP-1 agonists. Here we have some studies made already, which showed, for instance, for SGLT1 inhibitors, beneficial effects on heart failure, hospitalization, and renal function outcomes, either in a population with diabetes and already established cardiovascular disease or with high cardiovascular risk. Epagliflozin and canagliflozin reduce the risk of 3-point MACE. For EMPA-REG, we know that it reduced, or it was demonstrated to reduce 14% MACE. So it's really a very important event for our diabetes type 2 person. Also for GLP-1 agonists, they showed to reduce MACE, either in their first injectable way and then oral formula. SGLT2, the mechanisms underlying its cardiorenal benefits are still to be clarified. Anyway, there is a reduction of the levels of plasminogen activator inhibitor 1, PI1, leading to the loss of visceral fat and the restored adipokine balance. Also, there is a beneficial vascular effect through anti-inflammatory mechanisms. There is energy reflection and reduced inflammation, plus reduced autophagy and lower levels of CD36 and cardiotoxic lipids in the heart. There are also hemodynamic effects, improved cardiac remodeling, plus increased provascular progenitor cells, and decreased ischemia, reperfusion, injury, together with the inhibition of the cardiac sodium hydrogen exchanger. The renal protection of SGLT2 inhibitors are not yet clarified also. Anyway, we know that there is a promotion of diuresis and natriuresis. People think that the mechanisms are either renal or even extrarenal. For renal mechanisms, there is a decrease in intraglomerular pressure, an increase in erythropoietin and hematocrit, a reduction in inflammation and fibrosis biomarkers, and also in oxygen demand. For extrarenal mechanisms, there is, of course, blood pressure reduction, a modulation of renin-angiotensin-aldosterone system, and of the autonomous nervous system also. For GLP-1 agonists, the proposed mechanisms underlying cardiorenal benefits also not yet very clear, could be an anti-atherothrombotic effect, a reduction of inflammatory markers again, and an anti-hypertensive effect, maybe due to the anti-proliferative actions on vascular smooth muscle and endothelial cells, a reductions in oxidative stress, and an increase in nitric oxide generation and microvascular blood flow. Other standards of medical care have changed because of that. Recommendations were revised, as we all know, and the first line and initial therapies, depending on comorbidities, of course, and patient-centered treatment factors and management needs, as always, generally includes metformin and lifestyle modifications. As we all know, lifestyle modification is always the base for the treatment. The other medications, those we have been talking about, with or without metformin, are based on glycemic needs, of course, but they are appropriate initial therapies also. And they were not, the things were a little bit different. They are with or for diabetic persons with or at high risk for atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. Anyway, the most important is now the multifactorial approach to the disease. We have to have our targets, of course, on glycemic management, but also on blood pressure, lipid, with agents with cardiovascular and kidney benefits. That is, our target will be, from the beginning, the reduction in diabetes complication, of course, based on lifestyle modifications and diabetes education, as always. So ADA considers combined therapy with both SGLT2 inhibitors and GLP-1 agonists in persons with established or risk of atherosclerotic cardiovascular disease. For pharmacologic treatment of diabetes, of type 2 diabetes, we emphasize the incorporation of therapy rather than the sequential head-on as it was before. Therapies tailored to comorbidities, patient-centered treatment factors, and management needs, as I told before. ADA also has a table where we can be helped with the patient factors that we must consider to the therapeutic options, and the renal effects, the cardiovascular effects, which are now very, very important for our patients and us. We all know that the goals of care for diabetes are mainly to prevent complications and optimize quality of life, based on the assessment of key patient characteristics, the consideration of some specific factors which will help us to choose the treatment, the sharing of decision, as always, but very, very important, the agreement on the plan that we must manage after that, the implementation, the ongoing monitoring, and also the reviewing and agreement always of the patient and his family. But besides the drugs, we have many things that we don't know for the treatment of diabetes. We have, of course, the pharmacogenetics, which are very important and are being studied for novel drugs. We all know the variation of the individual response to some drugs. And maybe this could be explained in part by genetic variants. So there are studies and groups investigating investigating these genes, these genetic variations, and maybe some drugs can be tailored to some genes, and we may have each time more personalized therapy. Also, nanotechnology, it's a future perspective also. We have years of comprehensive nanoformulation research, which have contributed immensely to substantial progress in the advance of nanoparticulated drug delivery systems in diabetes. We have technological advances, big ones in nanotechnology, which offer compelling prospects in the future regarding the development of an efficient glucose-lowering therapy modality. So this is one future perspective also. But now we have 100 years since insulin discovery. Maybe in the future there is a cure in the horizon for diabetes. Some newer drugs with novel mechanisms of action targeting specific and type 2 diabetes have also shown a promise in recent clinical studies. The drugs I talked about, others like glucokinase activators and TCD3 monoclonal antibodies and glycines. Their efficacy, of course, needs to be evaluated in larger studies, but they are hopes. Only a few years ago, we had lifestyle modifications, sulfonylureas, metformin, and insulin, which were our weapons to fight diabetes. Now, there are approximately 40 medications in 10 categories to manage hyperglycemia in patients with type 2 diabetes. However, the availability of so many choices also makes therapeutic decisions and the options more and more complex. Finally, goals of care in type 2 diabetes are to achieve glycemic targets, of course, but also avoid unacceptable hypoglycemia to improve quality of life and also to reduce risk of cardiovascular and renal disease. Many agents now have demonstrated cardiovascular benefits in these patients with established cardiovascular disease and sometimes among those at high risk for cardiovascular disease. Also in patients with heart failure, with chronic kidney disease, some specific drugs have also been found to have these beneficial effects. The most common error in blood glucose management was, and it is still, clinical inertia, and we must fight against it. The progressive nature of type 2 diabetes and the need for intensification of therapies should be explained and understood by our patients. And of course, a patient-centered approach must be used to guide the choice of pharmacological agents. That is the most important. Considerations in choosing therapies include efficacy, cost, potential side effects, effects on weight, comorbidities, hypoglycemia risk, and patient preference. Thank you.